Thanks, Marshall. I'm going to share my screen. Hopefully everything, you can see everything okay. Great. Great. So good morning, everyone. I am Sherry Teeter, and I am a program manager with Community Connection 211. I want to thank Marshall and Paul for inviting me to speak on our digital transformation journey. There's 3 agenda items I want to talk about. First, a brief overview of Community Connection and the 211 services. 3 examples of how technology has improved what we do in our service delivery, and our next steps of our plans to continue to enhance our technology. So Community Connection is a nonprofit. We were established in 1969 and accredited by AIRS, which is our Alliance of Information and Referral System. Our mission is to create and improve access to services for people. We are a community-based organization and have multiple partnerships with other agencies focusing on community needs. We also deliver the services that is part of the 211 Canada, 211 Ontario networks. We deliver bilingual 24/7 services by phone, text, email, online service, online search, chat, and walk-in. 211 is one of the 3-digit dialing codes and is nationwide in the US and Canada. The CRTC approves applications for the 3-digit dialing codes, which are designed to complement one another. And this list shows the purposes of each. The 211 dialing code was approved for public information and referral services in 2001. We are most familiar with 911. But what you might not know is that 911 service actually started in London, Ontario in 1972. And 988 for mental health and suicide prevention services is coming in November of this year, which will be a very worthwhile and important addition to these 3-digit dialing codes. There are 6 independent organizations that deliver the 211 services across Ontario and operate as a single inbound contact center using digital technology to enable an efficient, seamless service for Ontario residents. I work out of the Collingwood Contact Center that covers the Central East area, which is that green area. However, calls will flow across all contact centers when their area navigators are busy. As a single service provider in the 211 network, we have 3 core services. We have inquiry service, community navigators, we have a resource database, and we have business intelligence data. Our inquiry services are operated by trained community navigators. They are skilled in financial and social needs screening, helping people identify, understand, and effectively use existing programs. They conduct follow-up in situations where someone is at risk and or vulnerable. Our resource database is manned by database curators. They manage a province-wide inventory of over 60,000 community, social, health, and government services. And they contact all these listed organizations and programs at least annually to update their information. Business intelligence, this provides our needs and trends, and we collect and analyze and report data about call details, caller demographics, service outcomes, growing service gaps and barriers to service access. This custom reporting supports advocacy and service planning in local communities. As I mentioned earlier, not only does Community Connection deliver the 211 services, but we also are involved in many community projects that leverage our 211 infrastructure. I've listed only a few of the community programs that we support, but today I just want to focus on the center circle of our 211 core service delivery and these 2 blue programs, which is the discretionary funds for income assistance and paramedic and healthcare provider referrals for their patients needing support for their socially determined mental health. So first, if we look at the core 211 services, which is this blue path, 211 receives inbound telephone calls, chat, or text from individuals inquiring about information. Sometimes it may be very simple, like looking for the walk-in clinic hours where no referral is necessary, but other times the need is far greater and complex, where the individual requires multiple referrals to meet their needs and follow-up calls to support until their needs are met. There are many barriers to this database, but the biggest barrier is that all of this information was a single caller event in our database. If a client happened to call 3 times, the navigator was not aware and could not see the reason for the previous calls or which referrals were provided. So the caller had to retell their story each time, which is definitely not very client-centered. Based on these needs, the business team and our inboard software team developed the idea for a new caller database called the Call Report Digital Platform, the CRDP. And this is more client-centered. This new database allows for a longitudinal record where all historical caller information will now all be kept in one place. So that when a call, a chat, or a text comes in, the CRDP will either create a new profile if it's the first time caller, or if it's a previous caller, we'll pull up the profile that is attached to that telephone number. So all the information will be there for the navigator to see. It'll allow the historical information from the previous calls, which means the caller doesn't have to repeat their story, and the navigator can review what resources were previously provided and then prevent duplicate referrals. That new database allows us to easily email the clients the resources offered so that they have them for reference in the future. And with all this information in one longitudinal record, we can start to track the client progress over time. So I know this is for the inboard team here today, I know this is really simplifying. This was a ton of work. This database is very complex, tied to I don't know how many hundreds of thousands of taxonomy terms. So it has been a lot of work to try to make this into this database that we call this longitude, that has these client longitudinal records, but very worth it in the end for client-centered care. Our next program that I want to talk about is our referrals from our healthcare providers and our paramedics. Community Connection receives inbound referrals from healthcare teams and paramedic services that identify non-medical needs for their patients. The process involved is very manual and based on sending and receiving of faxes, which requires the physician to then upload into the patient's chart. The barriers to this process are a lot of admin time, of manual entries for Community Connection and the healthcare providers. Sometimes the faxes were illegible, and we would have to try and contact the physician or the paramedic, which wasn't always timely. And of course, security concerns with faxing. Again, with our inboard software developer and our business team, our second project was to replace the antiquated fax referral process with an electronic referral system that the healthcare providers was already using, which was called Ocean. This project was an amazing integration between the patient's EMR and our database. It allows for the healthcare provider to refer directly from the patient's EMR with a direct feed into our CRDP and back again. It's a great solution because we're leveraging the EMR where the physician was already working with the patient. So the benefits, of course, are less administration time, as this integration allows the EMR fields from the referral form to auto-populate into the client record into our database. And the outcome report is also auto-populated from our database back into the EMR, the outcomes of this patient encounter. The healthcare provider doesn't have to upload any facts into the patient's chart. The information is ready for them at the next time the patient is in their office at their next visit. And it's also a more secure way to send personal information. The second program that I want to talk about is one where we work in partnership with United Way. 211 community navigators provide personalized assistance, connecting people with local services that support economic and social conditions. But sometimes there are no community resources available to help with the client's needs. So using that BI data I talked about earlier, United Way recognized that there were many community gaps to support individuals. Based on this, United Way partnered with us to provide us with some discretionary funds to give to clients when there are no community supports available. We then developed partnerships with agencies across our area to be a pickup location for those funds. This was a very worthwhile and impactful program, but there were a lot of moving parts and logistics to get this money into the hands of individuals quickly and barrier-free. To give you an example, this volume, since June 2022, $230,000 has been distributed to 867 community county households. It's very impactful, but we were using multiple tools to try and manage this program to keep track of the who, the what, and where, when, and how much throughout this process. We were using Google Forms. We were tracking on Excel spreadsheets, keeping them in secure shared folders. We were using emails to alert them when there was a new addition to their Excel spreadsheet. And we were often providing frequent financial reporting to United Way. So a digital solution with direct access was developed. We have replaced all of those tools with one digital solution, and all partnering agencies have access to this live data, their own specific live data. So the intake form is now built into the software, so there's no copying and pasting to an Excel form. It sends an alert to the appropriate partnering agency, no more emails. We can clearly see where the client is on the approval process. So if it's a new application, if the application is in progress, or if it has been approved. This form has mandatory fields, so the intake cannot be completed until the mandatory fields are completed, so we don't have to chase missing data. It automatically calculates the funds remaining on site, which is something we were doing as the lead agency, always tracking to see how much our partnering agency had left remaining on the site. So now the software does it automatically. So we can see how much is remaining. It even tracks how much is in their queue, waiting for the clients that are waiting to be picked up. It certainly has increased security, plus United Way has their own dashboard, so they can slice and dice the data based on needs, geographical area, total funds distributed over all the county or per agency. It's live data, and they can retrieve this information at any point, so they're not waiting on us to have to provide them with this data. Without this digital solution, I'm not sure we could have kept up with this program, or it certainly wouldn't have been as impactful. 6 months ago, we were probably providing about maybe $20,000 a month to individuals. January alone, we just spent $69,000. So this solution not only helps us manage the program, but it also helps the partnering agencies to stay involved. They're offering this service in kind through this program. And with the volume this large, the old way was a lot of admin time. They probably would not have been able to continue. So this has really been helpful for even the RALs as well, not just us to manage the program. We also will be able to leverage the software to meet the other needs of other programs that we're partnering with in the future. It's a great database for that partnering and sharing of information securely. So where are we going next? Well, remember I mentioned earlier the creation of that longitudinal record for our navigators? Well, we want to be able to share that longitudinal record with our partner agencies with some provisions. We call this the CIE, which is the Community Information Exchange. We are modeling this after 211 San Diego has been doing the CIE for years with great success. It's like your electronic medical record, but only for social needs. So the provisions would be, we can only share information on specific consented clients, and the agencies must meet criteria to be specific, to have specific levels of access, maybe signed data sharing agreements, two-factor authentication for them to log in. But the idea would be that we would have this one central longitudinal record where we would all be able to work together to see who's supporting what with this individual. The biggest benefit, of course, is coordinated care planning between health and social services. Their family physician, primary care provider would also be able to log in to see what community supports are in place for their patients. It ties the agencies together and helps to start breaking down some of those silos, because the agencies will be able to see who also is helping to support the client. It also allows for bi-directional referring between agencies. So it helps us to know whether or not the agencies has been able to accept a referral. So in our current state, our consent is with our client, not with our community partner, with agencies. So we need to follow up with the client to be able to see whether or not their transportation referral was able to meet their need of getting to their medical appointment. With this software, with the CIE, we would be able to see if they accepted that referral and provided that transportation to the client. So it really helps us to work as a more cohesive team to support the clients. Here's an example of what we hope the CIE record to look like. You can see in the yellow square, it would certainly take a look at their risk levels for their social determinants of health. And then it would also highlight their care team. So this is our future state that we hope to continue to work with INBORG on. It's very exciting. And I think that's all I have for you. Is there any questions?